Good noon to all and everyone here in this session, to all the participants, mentors, judges. Really, it's a very nice program. We all know that we have an old age tradition of teachers and students, which is this may help maybe some of you, maybe a good teacher. This may boost your confidence, or this may open up for you a new strata that you can be a good teacher. So I hope everyone will give in do his best or her best, and we'll all enjoy the session. I welcome judges, Dr. Pradhan Madam, Dr. Vadgaonkar Sir, Dr. Ambekar Sir, and I welcome all the mentors and the all the PG students. So for the details of the schedule program is you already know, but still the person who had done a lot of efforts in doing this program is Dr. Sumit. So I will hand over to Sumit. Sumit, please go ahead and just have a brief overview of the program so that they get everybody knows about it.
Thank you, Atul sir, for your kind words. And we would like to thank MOS President sir, Anaga ma'am, and Vardhaman sir, Aditi ma'am for putting all this together, and of course all the chief coordinators and all the judges. So this is basically the instructions have been shared, but every team has two members, two PGs. They will be presenting a 4 minutes of their presentation. The time is very important. Timer will be there. Even if they overshoot by 15 to 30 seconds, they will lose 1 mark. So I request all the PGs to stick to their marks. Once their presentation is done, judges can ask them questions, 1 or 2 questions. So we can keep it limited, because we have a limited time to finish all our 6 teams. Based on that, the marks will be given. Judges will be sharing marks directly with the coordinators. We have a coordination for that. And once one team is over, next team should be ready. So I will just read the sequence. Meanwhile, the sequence will be Dr. Anagha and Dr. Alisha, followed by Dr. Anuradha, Dr. Pooja Singh, then Dr. Shweta, Dr. Kubendran, then Dr. Sheetal, Dr. Abhishek Sharma, Dr. Smriti Pandey, Dr. Aishwarya, Dr. Priyanka Menon, and Dr. Sariki Maheshwari. We will follow this sequence unless there is some technical hitch. So with the judges' permission, can Dr. Anagha start sharing her screen and start presentation? Surendra sir, is it okay to start?
No problem.
Ambekar sir, to start?
Yes, I'm very much. I'm absolutely there. Yes, we are just waiting for you to start.
Yeah. Dr. Anagha, please share the PPT. We can see your screen. Go to the PowerPoint part and start the screen, the PowerPoint presentation. If you need any help, Dr. Anagha, we can speak up, because yeah, it's taking a lot of time. If you see any problem, don't try to sort at your level. Please ask us so we can help you out. Please make it full screen and start sharing. We can see the screen. Dr. Anagha. Dr. Anagha.
Hello.
Yeah, Dr. Anagha. Technical, Mr. Mukesh. Mr. Mukesh, please stop sharing screen by Dr. Anagha. And Dr. Alisha, if you're there, please share the screen. Dr. Alisha.
Yeah, just a second, sir.
Yeah.
One
stop
screen
sharing.
is actually being shared, so I'm not able to share it.
Please stop. Please start yours.
Okay. Shall I start, sir?
Yeah, please.
Okay. Good morning, everyone.
Timer to be started. Yeah, start.
Good morning, everyone. I'll be presenting congenital ptosis today. Abnormal drooping of the upper eyelid present since birth or occurring within the first year of life. It shall be differentiated from pseudotosis, which is the apparent drooping. It can be due to contralateral retracted lid or can be due to overhanging skin over the upper lid. The causes of congenital ptosis can be due to muscle issues, nerve issues, or due to sympathetic involvement, such as Horner syndrome. In the myogenic, there is muscle developmental issue. There is a dysgenesis of the levator muscle, which is replaced by fibrous adipose tissue. In the neurogenic, neurological dysfunction of the levator muscle happens. Patient usually presents with a complaint of visible drooping of one or both eyelids. There's heaviness in their eyes. There can be cosmetic concerns, DOV, and head posture abnormality. The most important step towards diagnosis is the history taking. We go for the age, duration, variability in ptosis. If there is any predisposing factor such as birth trauma, any surgery, we ask for any family history to look for any syndromic association. We ask for old photographs so that we can assess the progression of the ptosis or the age of onset. We shall also look for any associated features such as Marcus jaw unwinking phenomena, Horner syndrome, or if it is a syndromic involvement such as in BPES. The second most important step is the inspection. We look for the head posture, if the face is symmetrical, the brow position, the contour of the brow, if the lid crease is present or not, as the lid crease is usually absent in congenital ptosis. We look for frontalis overaction or any anophthalmos is present. After that, a whole ocular examination is conducted where we do the best corrected visual acuity to look for any amblyopia or astigmatism. We shall also do the slit lamp examination to rule out any exposure keratitis. The Bell's phenomena should also be seen so as to plan the surgeries accordingly, and the posterior segment is also observed. The given slide shows the types of congenital ptosis. The first picture shows simple congenital ptosis, as you can see on the right side of the face. The second picture shows BPES. In BPES, there is blepharophimosis, epicanthus inversus, and there is telecanthus present. If there is a molar muscle involvement, we can see at the center of the screen there is Horner syndrome. It is characterized by a triad, ptosis, meiosis, and anhydrosis. The given video shows Marcus gun jaw winking phenomena. It is a common oculofacial synkinesis in which there is an anomalous connection between the third and the fifth nerve. So whenever the patient is trying to move any muscle, the ipsilateral muscle, pterygoid muscle, there is improvement in the ptotic eyelid, such as during chewing or during any jaw movement, as you can see in the video. The ptosis evaluation consists of 5 main things: vertical fissure height, margin reflex distance, the LPS action, margin crease distance, margin limbal distance. But the most important out of these are margin reflex distance and LPS action, as we plan our surgeries according to those only. The margin reflex distance is the distance of the corneal light reflex to the center of the upper eyelid in the primary gaze. If it is more than 4 mm of the eyelid droop, it is considered as severe ptosis. In the next slide, you can see the
15 seconds left.
LPS function. In the LPS function, we block the action of the frontalis muscle. Why do we need to operate the ptosis? Because it can lead to visual deprivation or diffuse amblyopia or astigmatism.
Time up.
The treatment options can be fascinella servet, levator plication, or frontalis sling. If there is mild ptosis with good levator function, we can go for fascinella servet. If there is mild to moderate ptosis with fair levator function, we can go for levator plication or resection. If there is a severe ptosis and there is very poor LPS function, we can go for frontalis sling surgery. There are two techniques: Fox single pentagon and modified Crawford double triangle. So the conclusion is, by listening to this PPT, we should be able to differentiate between true and pseudotosis. If it is simple versus syndromic ptosis, we shall be able to grade the severity of the ptosis, assess the levator function, and plan our surgical management accordingly, and beware of the complications. Thank you.
Exceeded the time, ma'am. It was a nice presentation, but exceeding time is not what is we want. Judges, any questions for Dr. Alisha?
Hello, sorry, I'm not able to hear.
Sir, unmute कीजिए. Hello.
Yes, sir, I can hear you now. Your voice is breaking up, sir. Hello.
Surendra sir, नेट तुमचं वीक आहे. Ambekar sir or Pradhan ma'am, any questions from your side meanwhile? Ma'am, you need to unmute. Ma'am, you need to unmute.
Can you listen?
Ma'am, you're still muted. Mr. Mukesh, can you please unmute Pradhan ma'am?
Hello. Can you listen?
Yes, sir. I can hear you.
Head posture in congenital.
I think Surendra, if you cut down on the video, your sound quality would improve.
The video is continuing and sound is also.
Meanwhile, can I ask a question, Sumit?
Yeah, ma'am. Pradhan ma'am, you can.
Yeah, I just wanted to ask whether how do you do the gradation of the ptosis? Mild, moderate, severe? Do you actually measure it, or is just the coverage of the upper lid margin on the cornea? And is there any relation of the whatever gradation you do with the surgery, type of surgery?
Ma'am, we grade the ptosis according to the margin reflex distance. Normally, the upper lid covers the 1/6 part of the cornea. So we measure the margin reflex distance from the center of the upper eyelid and the center of the reflex. And if there is 2 mm droop, then it is graded as mild ptosis. If it is 3 mm droop, then moderate ptosis. And if it is more than 4 mm, it is considered as severe ptosis.
But that how do you measure in mm? With the device or just the foot rule?
Ma'am, with the foot rule, we can measure, or we can also use Shermer's strips.
Okay. And secondly, in congenital blepharophimosis,
Yes, ma'am.
would you like to operate upon both eyes altogether at the same time? And we require multiple, procedures in that. So everything at the same time, or
We can operate both eyes simultaneously, ma'am, for a better symmetry. We can go for bilateral frontalis link.
That's all, only frontalis link.
If the ptosis is very severe, then we can first disinsert the LPS muscle and then do frontalis link.
Okay, thank you.
Can we go ahead with the next presentation? Surendra sir,
Continue with the next presentation.
sir, somehow we are not able to hear you. I request you to please log out and then log in once again.
Hello.
Internet is poor from your side.
Hello.
Ambekar sir, can we shift to the next presentation, please?
Definitely.
Dr. Anaga, can you please share your presentation? Dr. Anaga, you are ready?
Yes, sir. Hello.
Dr. Anaga.
Hello. Hello.
Yeah, please share the screen.
Sir, can you hear me?
I can hear you, but we need to see your slides as to. You're still trying from iPad?
Sir, I can't. I'm not able to get a. Okay.
Dr. Alicia, if you can tell her to mail her presentation to you and you can share later from yours and she can present from her iPad, even that is okay with us. Because with her iPad, she is unable to do it. Dr. Anaga, Alicia, with permission from the judges, can we get back to them again?
Yes, sir, I'm sending it to you.
Yes, of course. Why not? Yes.
Ambika sir, is it okay, Pradhan ma'am? Because they are doing certain adjustment between them.
I think
So meanwhile,
we go to the next presentation to save the time.
Perfect.
fine. So we will go to the next team. The next team is Dr. Anuradha and Dr. Pooja Singh. Dr. Anuradha, you are ready? Can you share your presentation? Dr. Anuradha?
Yes, sir. Yes, sir.
Please share your presentation.
Sumit, one question: who is monitoring the timing?
Madam, there was a
Ma'am,
time on the right
I am
side.
seeing and it is there on the right side of the monitor. Once they start the presentation, na ma'am, तेव्हा timing येतोय.
बरोबर.
मी
पुढच्या
सांगतो
स्क्रीनवरती
मॅम.
हिने एक्सिड केला होता 20-30 सेकंदाने एक्सिड केला होता.
She exceeded her time. The
30 seconds we make it a grey time, na something.
So she crossed that one.
Acha,
Dr. Anuradha, please share the presentation.
Yes, sir. So my slide is visible.
Nothing is visible.
Nothing visible.
Dr. Pooja Singh, are you around in case Dr. Anuradha is unable
Yes,
to do
sir.
it?
Yes, sir. Yes, sir.
Please, one of you start presenting. Meanwhile, judges can send me marks for the first presentation. I can compile. The PDF you are sharing or PPT?
Should I start?
So
Sir,
before
PDF,
we send
PPT
it,
is not
you
visible.
want a consolidated marks or you want a split marks of each segment?
No, sir. I want consolidated.
That is fine. Okay.
Directly out of 10, whatever it is.
That is fine.
Group, sir. Dr.
Yeah.
Anuradha, if you can
Yes, sir.
start presenting, please.
Yes, sir.
Timer started
Good
already.
afternoon. Yes, good afternoon. I, Dr. Anuradha Vishnoy, first year resident from Grant Government Medical College and Sir JJ Group of Hospital, presenting my presentation on corneal surface anatomy and its clinical significance. Cornea is also known as kerato, is derived from Latin word which means horn-like structure. Cornea is thin at center, which is 0.52 millimeter in thickness, and thick at periphery, which is 0.67 millimeter. Surface area of cornea is about 1.3 centimeter square, which is cover 1/6 of the globe. It forms the fibrous coat of the eyeball and has the highest refractive power in the eyeball. Cornea is relative avascular structure, except at the peripheral region near the limbus, which is supplied by anterior ciliary artery, branch of ophthalmic artery. Anatomy of cornea. Cornea is a transparent, avascular, and watch glass-like structure. It is made up of many layers, which contain epithelium, which is 50 micrometer in thickness, later basement membrane, and Bowman's membrane, which is around 8 to 10 micrometer in thickness, then a stroma, which is around 500 micrometer in thickness, then pre-basement membrane, which is also known as Duar's layer, which discovered by Indian scientist Harminder Singh Duar. Then descemet membrane, which is around 8 to 10 micrometer in thickness. Then lastly, endothelium, which is around 5 micrometer in thickness. Let's see dimension and surgical anatomy of cornea. Cornea can be divided into two surfaces, anterior and posterior. Anterior surface, horizontal and vertical diameter are different. It is in elliptical in shape. Horizontal diameter is around 11.7 mm and vertical diameter is around 10.6 millimeter. Radius of curvature of anterior surface of cornea is around 7.8 millimeter, and posterior surface horizontal and vertical diameter is equal, which is 11.7 mm and shape is rounded. Radius of curvature of posterior surface of cornea is 6.5 millimeter. On surgical anatomy of cornea can be divided into four parts. The central 1.3 mm zone is known as central zone, then 4 to 7 is paracentral, 8 to 11 is peripheral zone, and 11 to 13 is limbal zone. Let's see optical properties of the cornea. Cornea main function is refraction of light for clear vision, transparency, surface. It provides surface smoothness, contour, and refractive index. The refractive power of center of cornea is plus 43 diopter. Air tear fluid is plus 44. Tear fluid cornea plus 5 diopter. Posterior surface of cornea aqueous humor is minus 5 diopter. The refractive index of cornea is 1.376. Functions of various layers of cornea. Epithelium, it maintains corneal homeostasis. It acts as a mechanical barrier. It contains tight junction which ensure corneal transparency. Abnormalities in this bonding system may result clinically in either recurrent corneal erosion syndrome or in persistent non-healing epithelial defects. Let's see Bowman's membrane. It names after English ophthalmologist William Bowman. It is a tough cellular layer that provides mechanical support to eye. Various surgeries, for example, laser, in which Bowman's layer is lost, in LASIK, Bowman layer is resected but is still retained. Corneal stroma is around 450 to 500 micrometer in thickness. It is a transparent, is rich in collagen, mainly type 1 collagen, but also type 3, 5, and 6 can be seen. Regular organization of stromal fibrils is necessary for optical properties, curvature, and strength of cornea. Alteration of this stromal structure in refractive and cataract surgery leads to post-op refractive error. In keratoconus, corneal stromal thinning occurs. Corneal thickness we can measure by pachymetry. Descemet membrane. In corneal ulcer, descemet membrane remains intact and may herniate out as a result of increased intraocular pressure, which is also known as descemetocele. Descemet membrane folds may occur in conditions, for example, inflammation, birth trauma, and inocular hypotony. Hepsia, these are curvilinear bricks that are seen in primary congenital glaucoma.
Time is up.
Lastly, endothelium, hexagonal cuboidal cells. Total cells is 6,000 cells per mm cube. In adult, around 2,400 to 300. Thank you.
Thank you. Any questions from judges, please? Pradhan ma'am, Ambekar sir, any questions?
As of now, because this was
Dr. Anuradha,
Yes,
see
ma'am.
the Descemet's folds and detachment is quite common complication after cataract surgery or any intraocular surgery. So there can be folds also. So you have not mentioned in your causes of folds that the ocular surgery can cause Descemet's folds, which is very common. So what is your plan of treatment for that? What would you advise? What would you do?
Ma'am, after post-op, we will give topical eye drops
Yes, that we always
and
do.
medical management we will do.
Yes,
To
medical.
decrease the stromal edema, we will give hypersol most commonly.
So normally, anterior segment OCT is advisable so that you know that whether there is really a descemet membrane detachment, DMD, or just the folds are there, and that's why the corneal edema is there. And you have to step up the steroids. And then depending on the picture on OCT, you can, we have presented a study on that. If you inject air in such a way that the descemet membrane flushes, it gets attached to the corneal endothelium, then that helps a lot. Otherwise, if you decide to wait that on its own, the corneal edema or the descemet membrane that takes long time. So that is one of the very simplest, remedies which every one of us can try. Otherwise, we have to end up with DSEC or something. So air injection is a very good choice, I think.
And you said hypersol, but then you have to mention what is the content, because many a times you go with this only. So what's the content?
Yes, sir. It contains sodium chloride, which is high in concentration.
What is the concentration?
So it will attract the water.
What is the concentration?
Around 0.03%.
No,
No.
that is the reason. Normally we go with the trade names only, but then we should be knowing what is the drug and what is the concentration of that.
Concentration is important in corneal folds. That's it. My
Anyway.
question. Can you listen to me now?
Very well audible,
Yes, sir.
sir. Very well audible.
So my question is epithelium and endothelium. Which one is the
Yes, sir.
most functionally active layer? Epithelium or endothelium? Functionally active layer. Which layer required more energy for its function? Epithelium or endothelium?
The, epithelium
Why?
endothelium. I'm not sure.
You are telling epithelium, it was correct. Because it is a multi-layer. It is
It's
a stratified
contain
squamous.
sodium pump.
Sodium pump is on endothelium. It is actually most active layer, but energy is required for epithelium, more for epithelium, because it is a stratified squamous epithelium, it is multi-layered, and the endothelium is having a single layer.
Yes,
That's
sir.
why even if it is active, it has got an endothelial pump, but functionally more active layer is epithelium. It requires more energy.
Thank you, sir.
Can we move on to the next presentation? Uma ma'am, you are muted. Surendra sir, can we go to the next presentation?
Yes.
Dr. Pooja
Sure.
Singh there. Dr. Pooja Singh, can you please
Yes,
share
sir.
your
I'm
screen?
giving a screen to Pooja.
Sumit,
I request all please present from the laptops and not from phones and the iPads. It's not very much recommended. This is competitive session. All of us are aware. It is very difficult and it does not look good to present from the phone or present from the iPad. Okay, Dr. Pooja Singh, please start your presentation.
before
Yes, sir.
she
They
starts,
should be,
wait.
they should be serious
Anu-
also. Na? They are presenting. You should be prepared with the laptop and all those things. It should not be a last minute hustle. Here, this is a competition. You are going through and going to present in the iOS afterwards.
Yes, Ambika sir, something you were telling?
Yeah, so these two girls are from the same team?
Yeah, Dr.
No.
Anuradha and Dr. Pooja are from the same team.
Yes,
Same
sir.
team. Fine. That's okay.
Yes, sir.
Yeah,
Okay.
Dr. Pooja, please start. Timer start, please.
Yes, sir. Yes, sir. We often do not give importance to the vitreous, giving the shape, structure, and function to the eyeball. Good morning, teachers, judges, and my colleagues. This is Dr. Pooja Singh from Grant Government Medical College and Sir J.J. Group of Hospitals, Mumbai. Now, the two pioneers of the vitreous anatomy, the Jan Wurst and the Shoji Kishi, used the complementary methods to explore the vitreous spaces, the former by injecting the liquid spaces with ink, and the latter by staining the formed vitreous with fluorescein, also called the study of the unknown. It is inert, transparent, hydrophilic, and a jelly-like structure, filling the posterior 4/5 of the cavity of the eyeball. Vitreous is 4 ml in volume and 4 grams in weight. It is mainly composed of randomly oriented collagen fibrils interspersed with hyaluronic acid. The vitreous body divides mainly into cortex and medulla or the nucleus. How is vitreous lost, and why should we substitute? Coming to that, it is used surgically in anterior and posterior segment operations, which are operatively used for establishing the intraocular pressure. Now, the indications of which includes removal of posterior lens segments and posterior dislocated lenses after the cataract surgeries, in retinal detachment, which could be traumatic, in giant retinal tear, and in detachment with complicated PVR, and in diabetic TRD with rhegumatogenous detachment. Now, when should we substitute? When the vitreous is more than 2 ml is removed, and in major vitreoretinal surgeries. The ideal vitreous substitute should include viscoelastic should have viscoelasticity with high surface tension, should be optically clear, and should be biologically inert, should allow the movements of ions and electrolytes, and should have a one-time implantation. It should be non-toxic, biocompatible, and biodegradable. It should be readily available at reasonable cost and storage. The currently used vitreous substitutes includes air, physiological solutions, expanding gases, perfluorocarbon liquids, and silicon oil. Now, the classification includes the three, the aqueous miscible, the aqueous immiscible, and the liquids. Coming to the physiological solution, it includes two of them, that is the Ringer's lactate and the balanced salt solution. It is better tolerated and but has no tamponadic effect and may pass through the retinal brakes, causing the RD. The gases are classified based on the expandability. The non-expandable ones are the air, nitrogen, and helium, and the expandable ones includes sulfur hexafluoride and perfluoropropane. Coming to air lasts for 3 days, and sulfur hexafluoride disappears in 10 days. It has a maximum expansion after 36 hours and is more effective than air. Now, coming to the perfluoropropane, it is inert, colorless, inflammable. It is 6 times heavier than air, has a maximum expansion after 2 days, and is 4 times the initial volume. Now, the viscoelastic substance includes sodium hyaluronate. Coming to the silicon oil, which is usually used, it is clear, transparent, inert, non-carcinogenic, is heat resistant, has a high surface tension. It is immiscible in water, has a refractive index of 1.404, and is lighter than water. Now, the perfluorocarbon liquids. It is colorless, odorless, non-flammable, and chemically and biologically inert. They are stable at room temperatures as high as 4 degrees Celsius to 500 degrees Celsius, and has a high specific gravity. It has a significant empowering effect and is optically clear. The combination of PFCl and silicone oil is useful in complex retinal detachment, which supports both the superior and the inferior pathologies. The silicone oil has a greater viscosity, less likely to enter the anterior chamber in eyes and are PFCLs, and resist the movement of PFCLs into the anterior chamber. Silicone oil tends to delay the emulsification of PFCL when both of them are used together. The future of these lies in polymers that could be hydrogels, smart hydrogels, thermosetting gels, or implants, and in cell cultures. Thank you. Thank you, sir, for giving this opportunity. I would like to thank all the MOS and all the teachers.
Thank you. Finished on time. Judges, any questions for
Yes,
Dr. Pooja? You can stop sharing.
What are the complications of silicone oil? Complications of silicone oil. Hello, can you listen to me?
Yes, sir. Yes, sir. Yes, sir.
Complications of the silicone oil. Any complication?
You can pass it, Dr. Pooja, so they can ask you a question if you want.
Okay, sir.
There can be immediate complications, early complications and late complication. What happens to silicone oil if it stays in the eye for a longer time? What will happen to it? What can happen to it? And in early period, post-operative period.
Sir, ma'am, reverse hypopain could occur.
Is that called as? You start beta blockers with the silicone oil injection? Anti-glaucomators are started?
Yes,
as
sir.
Madam has asked, early complications and...
Yes, sir.
Why beta blockers are started?
Anti-glaucoma drugs, sir. No, sir. Yes, sir. Beta blockers are started, sir.
Why?
So that to reduce the pressure of the to reduce the intraocular pressure.
Why to reduce the pressure? If it is there, raise intraocular pressure, and then main complication is early complication is rise in intraocular pressure.
Yes,
that's
sir.
why beta blocker are started.
Yes, sir.
Thank you, Dr. Pooja. Judges, can we move back to Dr. Alisha and finish the first team? Ambekar sir, is it okay?
Fine.
Dr. Alisha Dr. Anaga is ready?
Yes.
So Anaga is from which team now?
She's from the team 1, sir. Anaga is team 1, where Dr. Alisha already presented.
Okay, fine.
Dr. Anaga, please share your presentation. Yeah, full screen. Timer to start, please.
Good morning, everyone. I'll be presenting ophthalmic viscosurgical devices.
Press the arrow there. Yeah.
What are OVDs? OVDs are ophthalmic viscosurgical devices are transparent gel-like substances that have viscous and elastic properties. Major building blocks of OVDs are sodium hyaluronate, chondroitin sulfate, and hydroxypropyl methyl cellulose. OVDs are used mainly to protect the corneal endothelium, maintain the anterior chamber, ease for capsular access, for IOL implantation, and for better visibility. An ideal OVD should have the properties of viscosity, coatability, elasticity, and pseudoplasticity. They should be non-inflammatory, non-toxic, inert, isotonic to aqueous, and optically clear. In the spectrum of OVD, we have the dispersive OVDs and cohesives. Dispersives are low molecular weight, short chain, and low viscosity. Therefore, they coat and protect at high shear. The disadvantage is that they are very difficult to remove. As a result, can cause post-op IOP spike. In case of cohesive OVDs, they are high molecular weight, long chain. Therefore, they have high viscosity, so they maintain the shape at low shears. They are very easy to remove. The disadvantage is they do not provide much protection to the tissues. Viscoadaptives are a combination of both of these. At low flow rates, they act as retentive and maintain the AC, and high flow rates, they coat the endothelium and act as pseudodispersives. The applications of OVDs are mainly in cataract surgery, keratoplasty, trauma, posterior segment surgeries, NLD probing and dacrocystorhinostomy, and glaucoma surgery. OVDs in action, we can see how the dispersive and cohesive behave while injecting in the AC. Here we are injecting a dispersive OVD. We can see a wave of OVD that is spreading in the AC and coats the endothelium completely. In this, there is a cohesive OVD that is being injected, and we can see that it is not spreading, but it is maintaining its globular structure because of its high viscosity. Now, there are a combination of OVDs that are being used nowadays in cataract surgery, include the soft shell technique and tri-soft shell technique, in which both cohesive and dissuasive OVDs are used together. This provides both endothelial protection as well as maintenance of tissue. The complications of these OVDs include post-op elevation of IOP, capsular distension syndrome, IOL surface crystallization, band keratopathy, pseudo-anterior uveitis, and contamination with microorganisms. All these complications can be prevented only by one means, that is by clearing the OVD completely out of the anterior chamber by washing the chamber properly. In the recent advances, we can see two types of OVDs, one OVD with trypan blue and OVD with local anesthetic. In the recap, we can say that there are three types of OVDs available. The main functions are to maintain the AC, protect the endothelium, and for easy manipulation. Complications include capsular distension, IOP spike, and IOL crystallization. Only way to stop these are to thoroughly remove the visco out of the anterior chamber. Now, after listening to the class, we can go for a small quiz and you can say the answers. In endothelial dystrophy patient, what type of OVD will be used? It will be a dispersive type of OVD. In floppy iris syndrome, it will be a cohesive type of OVD. In case of a non-dilating pupil, we can use a cohesive type of OVD for better tissue mobility. And in dense cataracts, also for better protection of the cornea, we can use a dispersive type of OVD. Thank you.
Thank you for finishing on time. Questions for Dr. Anagha, please, from judges. Dr. Anagha, you can stop sharing.
Yes.
Questions for her?
Which OVD having a more complication like rise intraocular pressure and iritis? Which OVD is important for that patient? Which one?
Dispersive OVDs will be difficult to remove because they will remove as small pieces. So retention chances are more with dispersive OVD. So they will have more chances of intraocular complications.
Correct.
Thank you, sir.
Any question from other judges?
Any other questions from the judges? Ambika sir, Pradhan ma'am? Or should we go ahead?
Continue with the next candidate.
Fine. Thank you, Dr. Anagha. Pradhan ma'am, will move on to the next. Next will be Dr. Shweta Ghorpade and Dr. Kubendran. Dr. Shweta Ghorpade, you are ready?
Yes, sir.
Yeah, please share your. This is team 3, sir, now. Dr. Shweta Ghorpade. 2 teams are over. Dr. Shweta, please share your presentation. Any problem?
So is my slide visible?
Nothing is visible. Please try again. You're doing from mobile phone or iPad, something like that?
From laptop only.
Then please share. Please try and share. If you're unable, I would request you to take help from your mentor or any of your colleagues around. If it is becoming difficult, we will move on to the next team and you take your time and then we will come back to you last. Dr. Kubendran, Dr. Shweta.
So last half a minute I have lost.
No problem, sir.
Kubendran will start it.
Yeah, please, Dr. Kubendran, please share.
So this is a fresh team.
This is a fresh
Kubendran.
third team, sir. Yeah, Dr. Kubendran and Dr. Shweta. Dr. Anaga presented on time. Dr. Surendra sir asked her question and then got it done there.
Monish.
Sir, we will
Kubendran, can you please
present after some time.
Okay, fine. So they, so team 3 is unable to present because of some technical glitch. They will come back later. Team 4, Dr. Sheetal Kadam and Dr. Abhishek Sharma, are you there? Dr. Sheetal Kadam, Dr. Abhishek Sharma.
Good afternoon, sir. This is Smriti. Sir, I don't think they have joined the meeting.
They were informed about the presentation?
Yes, sir.
They didn't know they are
So-
participating.
So Sheetal and Abhishek are not there.
No, sir, they are not there.
4, I think, has maybe
So
removed
let
their
us
name
move
themselves.
to the
So
next.
next is Dr. Smriti Pandey and Dr. Aishwarya Gavit. This is team 5 separate, new team, sir. Dr. Smriti, you're ready with the presentation?
Yes, sir.
Please share your screen.
Yes. Is it sharing? No, this is.
Now we can see Dr. Shweta's presentation all of a
Okay.
sudden. Is it
Should I
request
exit
them
then?
to stop presenting? Yeah. Dr. Kubindran, can you stop sharing because we are moved on to the next team? Dr.
Is
Kubindran.
it Aishwarya or it is Shweta? Because on the screen I am seeing Aishwarya while
No,
the
sir,
presentation of
Shweta
Shweta.
has by mistake done. Dr. Smriti and Dr. Aishwarya, they are presenting from the same laptop, I suppose. Dr. Smriti, can you please share your presentation?
Sir, should I start then?
Any one
No,
of
who
you?
is sharing?
Smriti or Aishwarya, please start sharing, no?
Yes, sir, just a second.
So, Dr.
Smriti
Smriti.
Pandey is okay.
Sir, is it visible?
Yeah, it
Yes.
is.
Sir, I'm not able just.
Make it
Why
full
isn't
screen.
it sharing?
We can see the slide. Just make it full screen and start.
Yes, sir, but I'm not able to. I was able to do it previously.
You
I'm
need
not
to do
able
that
to do it.
enable editing first, I suppose, and then start.
Enable editing and then. Yes. It's not happening.
You can stop.
Sir, somebody else is sharing, I guess.
Not at all. Not at all. Your we can see your screen only. We
Okay,
can.
sir, I'll stop sharing and then I'll share again.
Yeah, please do it again.
Yes. Sir, is it visible?
Yeah. Move
Okay,
to
sir.
the
So now it is Smriti Pandey is doing.
Yes, sir.
Okay,
Good
fine.
afternoon, sir and ma'am, and my dear colleagues. This is Dr. Smriti Pandey from Grand Government Medical College and Sir JJ Group of Hospitals. I'll be presenting my topic, refraction in children, mentored by Dr. Shraddha ma'am. So, how is the refraction in children different from that in adults? We'll have to take in certain points in consideration, like the visual needs of the child according to the age. It varies. Not every child needs a vision of 6:6. We have to consider strong accommodative elements, risk of amblyopia, age-related emetropization prior to prescribing spectacles in a child. So when a child is born, he is born with a mean refractive error of plus 2.25. Considering plus minus 2 standard deviation, it can go up to plus 5.50 or minus 1.50. So a child can be born with myopia, hypermetropia, or emetropia. As very evident from the graph, the rate of emetropization is higher if the refractive error is higher. So how do we proceed refracting a child? We proceed by history from the parents. They'll give the history like child is not able to grab the objects, frequent falling, not able to copy from the boards. Then we'll check for the ocular alignments, visual acuity. We'll do retinoscopy, cycloplegic refractions, and subjective refraction. So coming to the type of visual acuity. First, there are 4 types. Detection. It's the ability to tell if the object is present or not. Resolution, to detect any separation of the contours. Recognition, where the child is able to resolve the details and on the basis of the cognitive cognition of the child, he is able to identify the objects. Then comes the vernier acuity, where the child is able to detect the misalignments. Why are those things important? Because say a child of 3 years, he is able to recognize the objects. So the visual acuity testing can be based on recognition. But a child of lower age group, he can just detect the objects. So there are certain tests based on these. Boeck candy test based on detection, where a child is asked to pick up different size candy beads, and preferential looking test, which is based on resolution, where child focuses on the striped pattern rather than the homogeneous pattern. In recognition comes the Landolt C or the Snellen's E and various picture charts like Cardiff Acuity cards and K pictures. Visual awareness in the light awareness in an infant can be diagnosed by indirect methods like pupillary reflex and blink reflex. Vestibulo-ocular reflex helps us in diagnosing profound visual losses in infants. Then comes the cycloplegic refraction, which can be done by various eye drops like atropine, which is used in children less than 5 years. And after that, we use cyclopentolate drops mostly. Side effects for these drugs have to be kept in mind. Then we'll go through retinoscopy in short. It is based on the Foucault's principle. That is, when a light is directed into the eye through the pupil, direction in which the light will move will depend on the far point of the eye. The far point varies with the different refractive errors. What we do here is we use different type of lenses to neutralize the fundal red streak glow. So then comes a question, why we do not prescribe based on the autorefractometer readings alone? It is because it induces some amount of proximal convergence that in turn lead to accommodation. But we still use them. Why? That is because it's a great way to start refraction, specifically if we are dealing with the cylinders. So for different age groups and different refractive errors, there are certain thresholds after which we prescribe the spectacles in a child. These thresholds decrease when we are dealing with the risk of amblyopia, strabismus, or anisometropia. So there are certain spectacle preferences in the child, how the spectacle should be, that the spectacle should be sturdy frame, deeply grooved, bridge that gives support in the lower part of the nose parts, quality of the string temples have to be good, and the polycarbonate lenses are preferred over the glass lenses. Educating the parents is very important. They should come for frequent follow-ups, they should look at the alignment of the child's spectacles, and they should look for the scratches on the child. Thank you. Sir, I'm done with the presentation.
Yes, that was a very good presentation.
Thank you, ma'am.
And absolutely on time.
Thank you, sir.
Dr. Smriti,
Yes, yes, ma'am.
I would like to tell you that in olden times we were taught that even under the age of 12 years, we always have to do atropine examination, especially if the patient has esotropia, accommodative esotropia or esotropia, and if you are examining the child for the first time. So the first examination has to be under atropine. We don't realize how much impact the accommodation has on the refraction in pediatric age group. And I have experienced that time and again. So your chart shows that up to the age of 5 years, atropine, 5 to 7, homatropine, like that. But that's what our protocol is.
Yes, ma'am.
We
In
still
general
go with-
practice.
Go ahead.
Sir, usually in general practice, we up to 5 years of age, we ask the parents to put atropine drops or ointment at home and follow up on 4th day. After 5 years, we generally go for cyclopentolate, tropicamide, and cyclopentolate. In general practice, what's done?
General practice, as you are a doctor, you should give a proper refraction to the patient to avoid the amblyopia. Then why you are talking as general practice? You are a doctor. You should prescribe the proper drug for the refraction.
Yes.
That is for retinoscopy.
But time tested is atropine. We still go with atropine.
Atropine is best.
Yes, sir.
And instead of cyclopentolate, which has more often than not, sometimes the child they develop side effects with cyclopentolate, like behavioral changes and all that. So homatropine is also a good alternative.
Yes, ma'am.
For that age, children.
And
yes, ma'am.
You said atropine drops.
Sir,
or
ointment. Yes, sir.
No, you said that for the age group that the atropine drops, but then always remember that the pediatric age group ointment is always preferred over the
Yes, sir.
drops, because
Yes,
other side effects with the drops are more marked with the drops than the ointment.
That's very correct, because the drops get absorbed very fast and the systemic side effects of the drops are seen in the patient. Whereas atropine, that too, we ask them to put very little atropine, not a lot of, large amount of atropine, so that the systemic absorption and the side effects thereby are less. It's safer.
Back question.
मॅडम सांगताना जरा सांगतो गव्हाच्या दाण्या एवढंच टाका आणि ते बाजूला लागलेलं पुसून घ्या.
हा, तर साइड इफेक्ट्स कमी होतात सर. ऍक्च्युली ट्रू आहे.
Congenital myopia. What is the refractive status in congenital myopia? What is the refraction in congenital myopia?
Sir, it can go up to 6 diopters, and but we wait for emmetropization to occur. If if depending on the visual needs, only we prescribe the spectacles to the congenital myopic patient.
Congenital myopia concept is a constant refractive status of the eye, that is fixed number.
Sir, it can go up to
but it will
6.
not change. It will remain as it is throughout the life. May I correct, ma'am?
Yes.
Ma'am. बरोबर.
I think congenital myopia can also progress in most of the patients. Congenital myopia also,
constant.
because
I
that
think
is
it is constant. I think congenital myopia it never progresses. The refraction remains as it is. If it is 7/7, it remains 7 throughout the life.
Okay.
No, you find out from the book.
Yes, sir. I'll definitely look into it.
even otherwise, they say that refraction is an art and science, but in pediatric patients, it's more of a taste of the consultant, examiner. I mean, he's the one.
His patients are at
I know.
So can we move on to the next speaker from her team?
Yes, sir.
Yeah. Dr. Aishwarya, can you please share the presentation and start?
Yes, sir.
So now Aishwarya is presenting.
Yes, sir. Yes, sir.
Okay, fine.
Good afternoon, judges and my dear colleagues. I am Dr. Aishwarya Gavit from Grand Government Medical College and Sir JJ Group of Hospitals, mentored by Dr. Shraddha ma'am. And my today's topic is newer intraocular lenses. So these can be classified based on design and features or based on anatomical locations. Multifocal aisles. These are single aisles with 2 to 3 focal points. This can be refractive, diffractive, or combination of both. The main difference between refractive and diffractive are the refractive gives excellent intermediate and distant vision, while the diffractive gives excellent near vision and distant vision. Toric aisles. Toric aisles, these aisles are used for astigmatism correction along with cataracts and other vision issues. They have different powers in different meridians of the lenses to correct the uneven curvature of the cornea. Extended depth of focus IOLs, which are EDOF IOLs. These EDOF IOLs create a single elongated focal point to enhance the depth of focus. These augment the intermediate and near vision. Next are aspheric IOLs. These IOLs reduce the spherical aberrations, as these have negative spherical aberrations which cancel out the positive spherical aberrations of the cornea, thus enhancing the vision. Accommodative IOLs. Accommodative IOLs, these mimic the eye's natural ability to focus. This changes position inside the eye as the eye's focusing muscles contracts. Light adjustable lenses. Light adjustable, these are photosensitive adjustable foldable 3-piece IOLs. These use photosensitive molecule technology to adjust the refractive hour of the implanted lens in response to ultraviolet light without modifying the cornea. Drug-eluting IOLs. These act as drug delivery devices. Mainly 3 techniques of pharmacological IOL modifications are present: coating, soaking, and loading the IOL haptics with a drug. NIRDA IOLs. These IOLs have a central clear zone and an opaque or tinted periphery. These offer optical correction and iris reconstruction in one sitting. Implantable miniature telescope IOLs. These are implantable Galilean IOL lenses. These contain number of micro lenses and magnify image in central visual field used in age-related macular degeneration patients. A newer technology in this uses mirror instead of glasses, which give a magnification up to 25 times. Rollable IOLs. These are ultra thin IOLs up to around up to 100 micrometers. These are implanted through 0.9 mm incision. Glued IOLs. Glued IOLs, these are fibrin glue assisted sutureless posterior chamber IOLs. These are indicated mostly in deficient posterior capsule. Sulcus supported posterior chamber IOLs. The haptics are optimized for placement in the ciliary sulcus, providing stability and support. Scleral fixed IOLs. Here, the IOLs is attached to the sclera using suture or other fixation methods. CMT flex. This is a new innovation model in scleral fixed intraocular lenses. Piggyback lenses. The piggyback lenses is an add-on IOL lens
in which the primary IOL is in the capsular bag and the secondary IOL in the ciliary sulcus. Electronic IOLs. Electronic IOLs are the world's first implantable lenses with artificial intelligence. These have a lens which is said to correct the distant vision, an autofocal lens for the near vision, a battery which is rechargeable, a sensor which detects the external light, and a microchip which regulates the autofocal lenses. Thank you, sir.
Nice, nice presentation.
Thank you.
Thank you, sir.
You can stop sharing.
Yes, sir.
Questions for Dr. Aishwarya, please.
A very good theoretical discussion on the various aspects of the lens IL, but in practice it's all subjective. So if I ask you which is the
Best
lens that you will prefer, or which is the ideal lens, what will be your answer?
Ideal lens, ma'am, it will differ from patient to patient, ma'am. Multifocal IOLs, ma'am, for younger patients or patients who have near work, we will prefer multifocal IOLs, ma'am, in them.
Why in younger patient multifocal IOLs? Why not in old patient multifocal? Let them use bifocal lenses. They will not happy with the lens.
So yes, we can use in them also, but the cost is also higher.
Why?
So,
cost. If you want to put the lens, or if patient requires the lens, you can put.
yes, sir.
Cost should not be the factor.
Cost is not the bar actually, but then for the younger group who wants to drive at the night time on the highways,
yes,
how would you counsel them?
Sir, this is known as photopsia, dysphotopsia, which occurs after putting the multifocal lenses. They experience glare while driving at night due to the light of the vehicles. So,
very correct. Which multifocal gives minimal dysphotopic problems?
Sorry, ma'am.
Which multifocal, according to you, gives minimal dysphotopic photic phenomenon? So that if a patient needs to drive at night, but he wants multifocal, then which one? Do you have any idea? Because unless you start your own practice, you don't get the feedback. What we do is we prepare a questionnaire, depending everything on what is the patient's profession, working distance, driving, what is the personality of the patient, whether he's very demanding, highly strung, or easy to make happy, all these things, and then you have to take your own decision with the patient's help. But in our practice, I think that Zeiss trifocal gives acceptable dysphotopsia.
Okay.
But each and every surgeon can have different opinion. EDOF is another choice, but then you have to clearly explain to the patient what you can do and what you cannot.
Yes, ma'am.
So,
Yes, ma'am.
with clear consent of the patient.
Yes, ma'am.
Yes, is my student.
Yes.
You
Yes,
forgotten.
sir. Yes, sir.
Nice to see you.
Same here, sir. Thank you, sir.
Okay, can we go on to the next team, sir?
Sure.
Yes, definitely.
Judges meanwhile can send me marks. We'll go. Dr. Priyanka Menon, you are ready?
Yes, sir.
Can you please share your screen?
Yes, sir. So is my screen visible?
Yeah, it is. You can start presenting.
Yes,
Timer,
sir.
please.
My topic for today is biometry. I'm Dr. Priyanka Menon, second year resident from DY Patil School of Medicine, mentored by Dr. Saroj Sehdev ma'am. Biometry is basically the measurement of anatomical dimensions of the eye. It incorporates corneal curvature, which is keratometry, axial length, and anterior chamber depth. Keratometry can be done in the following ways: manual keratometry, automated, and placido-based topography. This is how Bausch and Lomb keratometer looks. This is the Javel-Shiotz keratometer. These are the two manual keratometers. This basically axial length measurement is very important. It is important because 1 millimeter of axial length error can cause a 3 diopter error in the IOL power. It is done in the following ways: ultrasound biometry and optical. Ultrasound biometry is basically where the axial length is measured from the anterior corneal surface to the internal limiting membrane. It uses the probe, which is a 10 millihertz high frequency sound wave. It has a low penetration, high accuracy. It has further two methods: contact method and immersion method. In contact method, the probe is basically placed on the cornea and there is a possible error because of indentation. Immersion method is where there's a coupling fluid between the cornea and the probe. It reduces the indentation error because it is not it is separated by a coupling fluid. It is more time consuming and the possibility of infection always exists. This is how an ideal A scan looks. An ideal A scan basically has the following spikes: initial spike, two anterior corneal spikes, two lens spikes, one retina spike, and then there's sclera and orbital tissue spikes also. If the difference between the two eyes is more than 3 mm, more than 0.3 mm, the A scan should always be repeated. A retinal spike should be erect and high magnitude, and standard deviation should be usually less than 0.06 millimeters. Gain is a very important concept in biometry. Gain is basically a setting which is usually set at 50 to 70%. It has to be increased in cases of dense cataracts, and in cases of silicone oil, the gain is usually reduced. The drawbacks of ultrasound biometry are basically that it measures the anatomical axial length and not the optical. It can measure only up to the internal limiting membrane, and it is less accurate in special situations like long or short eyes, posterior staphyloma, and it always needs an experienced operator. Coming to optical biometry are of the following types: low coherence refractometry, partial coherence, and swept source OCT, which is the latest. Optical biometry has the following advantage: it is basically more accurate. It measures more number of parameters. It predicts something called as the ELP, which is effective lens position. It is non-contact. It measures the axial length and K reading together. It integrates all the IOL power formulae. Disadvantages, the most important is that it's very expensive. It's not used everywhere. It requires a visual acuity of the patient of at least 660 for fixation. Also, the patients with fixation issues, which include nystagmus, tremors, or lid abnormalities, cannot be suitable for optical biometry. It is not suitable in cases of dense cataracts, but the problem has been solved with the new machines like swept source OCTs. Coming to effective lens position is basically the effective distance between the anterior surface of the cornea and the lens plane, basically where the IOL is settled after the surgery, which is manufactured as a constant. It is important because a 7 mm shift in the anterior chamber depth will cause a 1 diopter shift in refraction tone. A constant is basically the theoretical value of the lens power, which relates to the K-metry and the axial length. It is IOL dependent, basically depending upon the type, material, IOL position, like covered in the IOL presentation. It is surgeon dependent, depending upon the incision placement, rhexis. It can be dependent on the biometry technique and value adjustments too. This is a picture showing how A constant, depending upon location, can change the value. As
you can extend for 30 seconds and try and quick finish.
So these are the formulae for the IOL power calculation, depending upon theoretical, regression, and refractive. This is the SRK formula, which was the first formula used. This is SRKT, which is better because it combines the theoretical and regression formulae both. These are the classifications of the older and the newer classification, and depending upon the type of eyes, the normal segment anatomy, and the axial length, the various methods, various formulae are incorporated. This is the classification which shows axial length and IOL formula. Depending upon how much axial length is, the different formulas can be used. For shorter eyes, Holiday 2 is used. For longer eyes, like 26 millimeters and more, SRKT is used commonly. There is IOL power calculation in special situations. In aphakia, you have to use aphakic mode and immersion technique is best suited. In pseudophakic, you have to lower the gain. In high myopes, you have to always do an ultrasound and you have to give a fixation target. In micro-ophthalmos, nano-ophthalmos, anterior chamber depth varies. In post-vitrectomy, you have to lower the gain because of silicone oil. Post-refractive surgery, there is a IOL calculator digitally available, which is called ASCRS, and it uses something called as Barrett 2 and double K formula, which is the Aramberry formula. And pediatric IOL calculation, you have to always undercorrect, basically cause hyperopia because myopia is expected. Thank you.
It was too long of a. You could have cut it down grossly.
Can you stop sharing any questions for her, or if you have taken out time for the questions, then we can move on to the next presentation directly.
She has already taken out the time, actually, she has extended too long.
We'll move on to the next presentation. Dr.
Yes.
Maheshwari, as you're there.
Yes, I'll start sharing the screen.
Yeah, please.
Shall I start, sir?
Yes, please. Timer, please.
Yes, sir. Good afternoon, everyone. I'm Dr. Maheshwari, resident from D.Y. Patil Hospital with mentor as Dr. Saroj ma'am. I'll be teaching today about treating of neovascular glaucoma. So basically, neovascular glaucoma is a secondary type of glaucoma which is caused due to the abnormal growth of blood vessels in the iris and in the anterior chamber, which is a serious eye condition. If left untreated, can cause blindness. And it basically occupies about 3 to 6% of all the glaucoma cases we see. So how does the disease actually happen? So conditions like diabetes, hypertension, and diseases like CRVO lead to retinal ischemia or hypoxia, which lead to the formation of angiogenic factors, which are produced and diffused all over the eye, which lead to the formation of new blood vessels, which are very thin and permeable in the iris and the anterior chamber, which finally lead to the occurrence of neovascular glaucoma. So what are the stages? There are 3 stages. The first stage is rubeosis iridis, in which the IOP is normal, but there is evidence of NVI. In the second stage, it is secondary open angle glaucoma, where the IOP is raised, but angle is still open. In the third stage is secondary closed angle glaucoma, where the angle is completely closed by the synechiae and the IOP is elevated. What are the different treatment modalities? So main goal of the treatment is to tackle the IOP along with retinal hypoxia. So it can be divided into medical and surgical options and further into 4 stages. Coming to the medical management, the first phase prophylactic management with the patient presents with some sort of NVI and normal IOP. So the first line is doing penetrant photocoagulation, where the blood vessels are destroyed by using argon laser and double frequency Nd:ARG laser. And the other one is anterior retinal ablation. It is usually done in patients where there's a cloudy cornea and PRP is not possible. And goniophotoccoagulation is also done, but it's very less commonly used. It destroys the blood vessels in the anterior chamber through argon laser. Coming to early stage, it is a stage where the IOPs of the patient is elevated. So the first modality used is medical therapy, where anti-glaucoma drugs like topical beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors are used, along with topical atropine and steroids to reduce the congestion, inflammation, and also pain for the patient. The second line of drug which is used is anti-VEGFs like bevacizumab and ranibizumab to stop the progression of the neovascularization and also to stop the active neovascularization. Myotics like pilocarpine and prostaglandin are absolutely contraindicated because they cause inflammation. Fill-in PRP and anterior retinal cryoablation, cyclophotocoagulation are used as supporting treatment. Advanced treatment is where there is synechial angle closure and elevated IOP. So the first we treat the patient with PRP and anti-VEGFs along with medical therapy. If it doesn't resolve, surgical management is the final solution. End stage is a case where there is complete angle closure with no remaining vision in patient presents with pain. So primary goal is pain control. So cyclodestructive surgeries like cyclocryotherapy, diode laser cyclophotocoagulation, and double frequency Nd:ARG cyclophotocoagulation are used. Retrobulbar injection with alcohol and enucleation are the final step where the medical and surgical options have been used and the patient is still present with pain. Coming to surgical management, the trabeculectomy with antimetabolites like 5-fluorouracil and mitomycin C are the gold standard surgical management. The next one is glaucoma drainage devices. It is done where the trabeculectomy fails or the patient has an extensive conjunctival scar and a refractive neovascular glaucoma. Devices like Ahmed valve and Bayer valve shunt are used. some newer modalities like surgical retinectomy with pars plana vitrectomy and treatment with alpha interferon and pigment epithelium derived growth factors have been recently developed and have been started being using. Thank you.
Nice presentation. Finished within time. Now,
What's the important thing to counsel when you go for the cyclocryo procedures or any cyclodestructive procedures? This is an important part of the counseling.
So we have to tell about the complications of the patient, like symptomatic ophthalmal, it can go to thysis bulbi, any infection, and while doing cryo also we have to explain the patient that. So shall I continue?
Yeah, please continue.
We have to explain them that the visual prognosis is very less and the complications of the patient, like the patient going to thysis bulbi, any ischemia problems and everything.
What is
but then-
90 days? Sorry. Continue, Madhav, continue.
No, I just wanted to say that because initially after doing any cyclodestructive procedure, the pain exacerbates to a very great extent.
So first, initially
So
the
that
pain
has to
increases
be
for the patient.
increases. Yeah, so patient has to be made aware because otherwise after for 36 hours, patient will start eating your head saying कि वो pain बढ़ गया है.
Yes, the pain
And
not reduced. Yes.
So that is the most important parameter that you have to make the patient aware.
Yes, sir. We have to explain that the pain
Exacerbation in the
increases.
initial stages, and then it takes about almost 10 to 15 days to gradually it becomes less. So this is the most important part that you have to consider.
Yes.
What is 90 days glaucoma?
Sir, it is seen in CRVO, sir, where after the patient presents with around 3 months after the disease, the patient presents with a glaucoma condition.
Neovascular. This is neovascular.
Sir?
Then. This is neovascular
Yes, sir.
glaucoma.
Presents with neovascular glaucoma. Yes, sir. After 90 days.
Okay. Fine.
Sir, because of the CRVO, the initially after 2-3 weeks, starting from 3 weeks to 3 months, there'll be slightly production of the, because of the ischemia condition, there'll be production of the angiogenic factors, because of which there'll be slowly development of the new vessels, and after 90 days the patient can come with conditions like this, neovascular glaucoma.
Okay. Good. Next slide.
Thank you, Dr. Maheshwari.
Thank you, sir.
We can start with Dr. Shweta. Dr. Shweta, you can start presenting. Timer, please. Meanwhile, judges can send me marks for this team. Dr. Shweta, start presenting, please. Dr. Shweta, you're there? Dr. Shweta, your timer has already started. You can move on to the next slide.
Yes, sir. Good morning, faculties. Happy Independence Day to everyone. Myself, Dr. Shweta Godbade, first year resident from Grand Government Medical College and Sir JJ Group of Hospitals. Today, my topic is contraindications for laser refractive surgeries. We can start with the laser acronym. Laser is light amplification by stimulated emission of radiation. There are various lasers used, such as excimer laser at 193 nanometers, solid diode laser at 680 nanometers, femtosecond laser at 1053 nanometers. Laser works on the principle of photoablation and photo disruption. In photoablation, cornea has extremely high absorption coefficient at 193 nanometers. Photons has sufficient energy to break carbon-carbon and carbon-nitrogen bonds of peptide in corneal collagen molecule. So collagen polymer ruptures into small fragments and discrete volume of corneal tissue is removed. In photodisruption, laser energy is absorbed, which results in plasma formation. Expansion of plasma creates cavitation bubbles, which separates the plasma, tissue plate. So these are the various laser ablation corneal procedures: photorefractive keratectomy, laser subepithelial keratomycosis, laser assisted in situ keratomycosis, and epithelial laser assisted in situ keratomycosis. These are the procedures: LASIK, epithelial LASIK, PRP. Indications for refractive surgery is myopia, hyperopia, and astigmatism. Coming to contraindications, there are two types of contraindications, systemic and contraindications and systemic contraindications. Whichever that 18 years are not suitable candidates for refractive surgery. Pregnancy and lactation, there is fluctuation of refractive error and unstability of film status. So we should also avoid exposure to fetus or neonate to medicine that may be required after LASIK procedures. And in hypertension and other ocular vascular occlusive disorders, there is risk for vascular occlusion while rising intraocular pressure during plaque creation. There are other diseases such as diabetes mellitus, immunodeficiencies, autoimmune and connective disorders, systemic infections, and drugs that hamper wound healing protein. In ocular contraindications, there are contact lens uses such as prolonged use may lead to thickening and thinning of cornea that may interfere with preoperative evaluation. Also, prolonged use of contact lenses leads to hypoxia that cause stromal vascularization that may interfere with flap making. Fortunately, most of these changes are reversible with discontinuation of contact lens use. Generally, we advise patients to stop wearing soft contact lenses for 2 weeks and rigid lenses for 1 month. To measure the corneal thickness, we use it. And patients with unstable refractive errors are also not suitable for candidates for refractive surgeries. Refraction should be stable for 1 month. In cornea, there are various diseases such as keratoconus, keratoglobus, pellucid marginal degeneration on eyes of retinoid therapy, severe dry eyes, exposure keratitis, keratoconjunctivitis, sicca herpes zoster, ophthalmicus herpetic keratitis, which are absolute contraindications. Other ocular conditions such as glaucoma, irregular astigmatism, cataract, retinal diseases are also contraindications. Unrealistic expectations patients keep that is the yes. And non-compliant patients to post-operative instructions are also contraindications.
You can stop sharing. Any questions from the judges for her? Any questions, Ambekar sir?
No, actually, her topic was she wasted more time on the initial theory part of the lasers. Actually, she should have reached to the because her topic was about the contraindications.
Okay.
So that's about
Fine.
Yeah.
Let's move on to the next person. Dr. Kubendran, can you please share your presentation? This is the last presentation of this session. Dr. Kubendran.
Yes, sir.
Meanwhile, for the judges and for the Atul sir, Santosh sir has requested that post this session, we join a meeting with MOS and I will be sharing the link. So once this session is over, we'll join there for all the judges and Atul sir.
Okay.
You can start presenting. Timer, please.
Good afternoon, ma'am. Happy Independence Day. My topic is operative examination in glaucoma. I'm first year residents in Grand Government Medical College and San Luis Obispo Hospitals.
Go on that arrow left side so you can move to the next slide.
Yes. The term glaucoma refers to a group of progressive optic neuropathy characterized by cupping together with the loss of retinal ganglion cells and axon corresponding pattern of vision loss. There is a new terminology like the pre-perimetric glaucoma. This describe the glaucomatous optic neuropathy before development of visual field changes. In one group of studies, shows 50% of the patients of ocular hypertensives convert to treatment based on the optic disc changes without field changes. 60% of the ocular hypertension have RNFL defect up to 6 years before they develop visual field defect. First, we see optic disc size. Normal median vertical diameter, we always use vertical diameter for non-glaucomatous discs, is 1.5 mm in Caucasian populations, normally 1.5 mm to 2.2. And approximate is vertical cum disc ratio more than 0.7 loss of limb to disc margin anywhere outside the temporal sector strongly suggests glaucoma. Ophthalmic signs of glaucoma. There are divided into generalized and focal. In focal, notching of the rim, vertical elongation of the cup, and cupping of the disc margin, and nerve fiber layer hemorrhage is also there. In generalized, we saw just asymmetry of cup and loss of the cup and progressing of an enlargement of cup. There are spectrum of changes we saw. From starting of loss of tissue in notching of the neuroretinal layer to diffuse concentric enlargement of the cup. Selective loss of neural rim tissue we saw in ISNT role, mostly in infratemporal region, then followed by superior-temporal region, then nasal region, finally the temporal region is there. Because of starting from inferior temporal and superior temporal, the vertical elongation of the cup we see. Local thinning of neural rim tissues reaches disc margin, resulting sharp rim. Whenever the retinal vessels crosses the sharpened rim, creating appears as bionetting at this cage. Deepening of the cup is predominant pattern of AV glaucomatous disc damage, and continuous deepening of the cup causes underlying the lamina propulsa as seen as a lamina dot sign. Technique of optic disc evolutions. Where we saw from direct ophthalmoscopies, indirect ophthalmoscopies, fundus camera photography, slit-lamp biomicroscopy, and confocal scanning laser tomography, and optical coherence tomography. When we saw from the slit-lamp biomicroscopy, we have used different type of lenses. This is 60D lenses, 70D lenses, and 80D lenses. Whenever you correction factor is needed for, depending upon the lens we use. Like 60D lens is used, we have the height of the slit equal to disc diameter. If we use 78D lenses, multiply the height of the slit by 1.1. If 90D lens is used, multiply the height of the slit by 1.3. Thank you.
Thank you. Any questions for Dr. Kubendran? Any questions from judges? Kubendran, you can stop sharing your screen.
Yes, sir.
Ambika sir, Surendra sir, Uma ma'am, any questions? Atul sir, any question from your side?
Can you measure the disc cup size from the direct option scope?
Sir, we can able to see. Yes, sir.
Can you measure the size of the cup by using direct ophthalmoscope? Because
No,
you
sir.
have an ophthalmoscope with you, and then there.
We just see the deepening of cup and anything, but not in correct millimeter size.
You don't know. What are the parts of the direct ophthalmoscope which is used for the measuring the lesions in fundus? There is one grid we call as that can be used to measure the lesions on the fundus grid. You go and just find out the grids are there. What is the use of grid? You can apply that grid and you can measure approximately this is the size of the cup and size of the disc and size of the lesion. Okay. Sir, continue with the next.
Sir, done. Surendra sir.
Okay.